You kids are soft. You lack discipline. We landed on the moon!
You didn't earn the knowledge for yourselves, so you don't take any responsibility.
It's like we've forgotten who we are. Explorers, pioneers.
Well, we're back for episode 46, and Colin, who is in shadowing from Logan, might have a special intro for us. By the time you've heard this, you would have known already, but we'll see. And if I look at this guy, I just can't, I don't know, I can't take him seriously. He's over there smirking at with a mustache, drinking a cordial of some sort. But what's been going on since episode 45 all the way back in May?
45. May?
Oh, boy. Yeah.
2 or 3 months in the life of Seth Graham and Alex Collins, a lot that goes down.
May?
We moved
On
July 4th.
I can't remember if I had done my half Ironman before the last episode or not.
What date was that?
It was
May 10th?
No, you had.
Yeah.
Just kidding.
Yeah.
I don't know if you debriefed. Well,
it was pretty miserable.
Let's check the calendar to see exactly when the last one was.
I bet it was close to that.
Whatever Mother's Day weekend was.
It was that week.
Oh, no. April 17th.
Was our last one. So I did a half Ironman.
Yeah. How'd it go?
Yeah, it was pretty miserable. Our swim got canceled, double red flags. The bike was like a time trial start. So 2 people went every 5 seconds for bib numbers going from bib 1 all the way up to, I think there was like 1,800 people there. It rained and hailed on the entire bike. The last like 15 miles, you went straight into a headwind of like 40 miles an hour. Yeah. And then I had to go run after that. And sun came out, it's 3 loops. Back half, it was super hot. Front half was 40 mile an hour winds as well. Hat flew off a couple times. Yeah. And then we got done, thankfully. And half the field didn't get to finish because they canceled it because the second round of storms came in. So I think 1,800 started, and I believe only like 700 actually got to finish.
Yeah. I mean, driving. So we drove down to watch it race because we were at the beach anyway. And we stayed in Pensacola, drove to PCB that morning. As we drove in, y'all were on the bike. I was like, he's biking in this right now. And it almost was the same timing because I was watching him on the live and we were driving up as the bikers were coming on the course, probably mile 35-ish. And just seeing their faces, I said, oh, buddy, this is a long day. And then we got out on the course watching him run. I was getting pushed over by the wind, standing there.
Have you guys seen Caddyshack?
Yeah.
The scene where the minister is out there trying to play the last round. He's like, I don't think that hard stuff's going to come down for a while. Like just leaning into the wind, hitting it. The frog comes out of the hole. Yeah.
He did pretty good.
Yeah.
All things considered.
I think I got like 50th overall.
Not bad.
It isn't terrible. I think I was like 8th or 9th maybe in my age group. I don't know. We'll take it.
And correct, have you done another triathlon since then?
No.
He retired.
Wasn't great for morale.
It mentally just destroyed me.
Still
Like-
training. Just
Like, I feel like I'm a pretty mentally strong guy, but that was just like 4 hours of just like, think of all of the weather elements except like snow. And like, that's what we went through in 4 hours. It just was not ideal.
next triathlon he's going to sign up for is Nordic Man. So get the snow element down, then you know you got it in the bag.
I say we just do a Spartan race all on the bike.
Like carrying it through the...
Think about it. I don't know. Just think about it.
Got to clip in for that one. Yeah. And I guess we should introduce Trent McKeown over here. So he's our intern for the next, what do we got, 2 more months of the year, something like that. From, where are you from?
Palmer.
Originally
from
Where are you
Ohio.
from? Logan. And this is also Colin Sargent. So his dad, Tim, practices in Huntsville, which if you're not familiar with Alabama, is about 2 hours north of us. And I've known Tim, I don't know, like 7, 8 years now. He's been to our clinic for a couple continuing ed things. And are you going to practice with your dad? Do you know? Is that a bad question to ask right now?
No, it's up in the air.
Yeah, up in the air. We'll just leave that one for that. Yeah. And you're in your last trimester, right?
Yeah.
And then Trent's going to go back to Ohio and work with
Derek Ressler.
Derek. Yeah. And I've known Derek for quite a while too. Great guy. And the mustachioed man, everybody knows Alex. Seth was just telling about his triathlon. I'm not going to introduce myself. Any more updates?
We'll have Troy probably on the next episode.
Nabrisco. Troy Briscoe coming in from Parker. He'll be here Tuesday of next week because Monday's Labor Day. And yeah, so we'll have another podcast for the next season. Oh yeah, this season. So we're going to do 10 episodes of the week in review, starting with this one. This is episode 46. So I have 10 episodes every other week, and then we're going to have Farmcast episodes with interviews on the off weeks, a week in review. We got the first few interviews already set up. So we have Kyler Brown coming on. We have Courtney Conley coming on. She has a new book coming out here pretty soon. And then a couple other people we're working on. So yeah. And if you have any requests, drop a comment. Make sure it's along with a 5-star review. If it's not, I'm not going to take your comment. So that's how it goes. Yeah. Anything else? Let's get rolling. So we don't have a specific case today. Well, we do. We have 2 cases that I just thought were pertinent to discuss in terms of both the clinical side and then also just some general knowledge on approaches to surgery, both before, during, and after, even though none of us, are you guys surgeons? No,
Not yet.
Didn't take that board exam.
I did surgery on Seth's eye on a run one time.
How'd that go?
I got the bug out.
I tried to give somebody stitches on a school bus at like 3 a.m. Didn't go awesome. But we'll just leave that for another time. Yeah. That's a whole other story. So 2 different patients. So one is a now 52-year-old, really competitive Highlands game athlete. So behemoth of a man. And I think I said behemoth of a man, which is actually correct. Huge guy, Highlands game. So Highlands game is, from what I understand, 2 different shot puts. So it's 2 different weight rocks or stones. The sheaf toss, which is basically a bale of straw with a pitchfork. The caber toss, which is a telephone pole toss. Hammer throw, but it's a rock. And keg toss. Yeah, over a bar backwards. I think that's all. So this guy is going to compete in Worlds 2026. So last year he got invited to nationals and does some local competitions. And we started working on shoulder. And if I back up a couple months prior to me working on shoulder, he had an SC joint separation from one of the events. And that can always preclude some bigger shoulder pathology. But anyways, we started working on shoulder, and about 5-6 visits in, I'm like, hey, I don't think you need surgery, but we need to have an MRI and at least an MRI. If you want to do an MRI and an ortho consult, I don't think that's unwarranted. Sent him to our conservative orthopedic that we like to work with locally here. And he actually recommended surgery for what I knew he had going on, which is slap tear and just some other degenerative change in his shoulder. So he goes in for surgery. So we'll leave that one on the table. Our other guy, opposite shoulder. So that was the right shoulder injury. This is the left shoulder injury. This guy owns a Taekwondo studio. So extremely physical, has to show people how to do different things. We're working on his shoulder for a while. In my opinion, his shoulder was really good. Like functionally, it was good. He had pain with a lot of things, but like he didn't have any weakness. There were very few things he wasn't able to do except lateral raises, which I tried to say just not do this for a while, but kept going. So then same thing. He got about maybe 6-7 visits in and he wanted an image. And I was like, yeah, because he's worried that, if something gets too bad, he won't be able to do his job, which I can appreciate. So I send him for an ortho consult because we brought that up and he goes, I think I'd rather do that. And he, I think more or less said he wanted surgery when in the office. And again, slap tear and some mild degenerative change. So both these people have basically the same surgery. And when I send them off, I'm not looking to like babysit these people. We don't do direct post-op PT in here. And we'll talk about what we do like to do. But here's how this went with both these people. Same surgeon, unbeknownst to our team, both of them are given 4 weeks of basically at-home post-op PT via an app, right? So, hey, this is what you do. It steps up. Both of these guys are motivated. So they both did what they're supposed to do. And the Taekwondo guy probably went above and beyond, just he's like, stuff seemed too easy. I was doing a little bit more. So then at 4 weeks post-op, they both show up to the physical therapy office that's, 2 doors down from us, where they're doing post-op PT. So this is the first, I want to kind of talk about these cases and then, well, what can we take away from a clinical side and then also a patient side. So from a clinical side, it's, did either one of these guys really need surgery? So, and again, I want you guys to weigh in on this. I think the thrower, the Highlands game guy, probably did. I think it would have been hard to keep going. But the crazy thing was with him, the week before we sent him in for the ortho consult, he threw a PR. So it's like you can operate around pathology. So that's a good clinical note to realize like function can remain high even though you're tearing stuff apart. That's, there's a lot of aspects of that. The other guy, I didn't think he needed surgery at all. I was just trying to he needed some peace of mind, and it ended up in that surgical route. So is there anything that you guys kind of have a checklist or that is like a red flag ever like, ooh, this is absolutely surgery? Or, if somebody comes at you like, hey, I think I need surgery, and then you can kind of talk them out of it based on some criteria evidence, anything that comes to mind?
I was going to ask you with the first guy, did he...
The Highlands game guy?
Maybe you already said it. Did he, whenever he was when you did orthos on him, did he buckle? Did he have weakness with all those?
So you would have no weakness, but also if you look at these guys' shoulders, they're like as big as Seth's head. So we can bulletproof around pathology with muscle, and that's going to be hard to know. Well, is he going to fail now? Yeah. I mean, he had basically half of his labrum was torn off the posterior aspect of his glenoid fossa from a slap tear, and he threw a PR. So he can just manhandle that stuff. When we talk about his post-op, I think that's part of what's made his post-op PT a little tough for him. That's just a little bit different. But yeah, no buckling. The other guy that I didn't think he needed surgery, again, maybe mild weakness, but due to pain. He just didn't like doing, resisted external rotation at 90, empty can. But he was one of those cases that I talk about where the Taekwondo patient, all of the orthos were slightly painful. So it's not indicative of a succinct pathology. What became clear was the position he hangs his shoulder in, the things that were painful, and some of the positive RP tests. Oh, you definitely have a slap tear. We just know. Now, do you need surgery? Probably not. We should rehab around that. In my opinion, I think he just got gun shy. I don't want to not be able to use my shoulder, which lo and behold, PT took way too long. And, he still is not at 100% for how far out is he now? 18, 19 weeks or something like that. So pretty far out.
Makes me, I was thinking of a patient that I have who plays, she's a semi-pro pickleball player. And she had already had a rotator cuff surgery when she first started seeing me. I think maybe second trial of care, she came again during her season. And we ended up, she wasn't going to have surgery during the season. She wanted to just keep playing. And then knowing that she was probably going to have surgery at the end of the season, which I did send her out for, because for some of the ortho tests that I was talking about, she had weakness and pain, but it was the same in all positions, whether she was seated, same with supine, she would still buckle. So sometimes if I see a difference in those same tests where they can't resist seated, but then they go supine, oh, that's fine. They get more stability from the table. And then, okay, the likelihood of that, the integrity of the structures in their shoulder is there. They just can't control it as much when they have sitting or standing. And she had a good outcome with that surgery, but
I think for me, some of my criteria is how much is their everyday life getting affected?
Yeah. I think that was the Taekwondo guy. His tipping point was, I can't do a lot of things just because of pain. And then he goes I'm not throwing punches, I'm not demoing stuff. And I think that's where he's I don't like that. And he's what do I got to do about it?
So I'll have that one as I guess it's my number 3-ish. The weakness and pain is another one. And then if I've changed at least the audits that I'm going after, and those have gotten better, but they're everyday life and or pain level has not changed. We probably need to look at something underlying here, because you can change stuff in office, but that protective pattern just comes right back just over and over and over again. They have to weigh the option of is the patient actually doing stuff outside of here, but
and
still,
for
change much.
The patient base listening to this, what Seth's saying with an audit. So if we're saying, how your neck moves or how your shoulder moves or muscle, tension or trigger point, goes away or gets better, but you're still having all this pain and can't do things, that's showing oh, we're improving function around or at the area of complaint, and you're still having the same amount of pain and dysfunction locally. And it's oh, that doesn't make sense. That's indicating more of a pathoanatomical, a legit injury. And then what Alex was saying, for those that may not have caught it, if you're in an orthopedics office or somebody's office and they're doing, you're sitting on the table and they're going through all these resisted range of motions and all these things, and then you lay down, your shoulder blade is on the table. So it's now it's somebody holding me and they're testing my balance, like it's going to be better. Now the table's holding my shoulder blade, and you're like, oh, that stuff's way better, which could indicate, oh, it's not a pathology, it's how you're using your shoulder. You know, however we define that, you know, is kind of a little bit more nuanced.
A lot of times the weakness sometimes is like tough to like suss out in people, just because like some people are just like super strong like that guy.
Yeah.
Other times it's like they've already created, so by the time they hit us, I feel like they've already created good compensation to where like when they like do resisted ranges that's supposed to be testing certain muscles, they've already compensated with another one, and they're just like, yeah, that hurts to do. But yet it's like, if I'm going for supraspinatus, right, like they're just going to get super like trap heavy, right? So you almost take that muscle completely out, and it's like,
That's it. This lady was a little different too, because unlike these two guys, her shoulder strength was not nearly the same as what theirs was. So her ability to compensate and use other muscle groups to stabilize that shoulder was not going to be nearly, which now we're working on strength, but I don't think I could have done that then, because she had partial and full thickness tears of all 4 rotator cuff muscles.
And I think there's 2 notes here. We always talk about most orthopedic tests, or the orthopedic tests that are actually worth a damn, are testing like integrity of a tissue or a complex. So if you think of classic knee ones like ACL, like you'll have an appreciable amount of movement on like a drawer test, right? So if I do like a labral shear test or something, like it's not just a pain, it's like, do you actually feel like they can't do it? Because remember, the 5 out of 5 on like muscle testing is not like, can they hold it for 10 seconds? It's the initial response. Like everybody, like I can win against anybody if I just hang on them for a little bit. It's that initial, like, and then if they give up, that could just be pain growing, or it could be even central, you know, not even anything local causing pain. So it's also not like, I'm going to hang off you for 3 seconds. Like, oh, you buckled. It's like, no, like initial, like half second, like press. Oh, you did fine. Cool.
Yeah. Hers was, I put 2 fingers.
Right. So that's, And
the other one as well, if I'm looking for integrity, is I will change the fulcrum. So instead of being way far out, I'll move closer and be like, can they still hold it? If they can't, I'm like, yeah, there's something wrong with that tissue there.
Absolutely. So last piece on the orthopedic tests, we all learn the names of these tests. I forget them, but we learn the names in school. The names and the positions don't matter. And I've even seen like Bill Tortorello and Robert Lardner, like if they're doing shoulder orthopedic tests, like multiple angles of the same test, trying to denote, is that like a certain part of subscapularis and things, which I think you'd probably get too nuanced and maybe get lost in the weeds. But also understand, what am I actually testing? Not just what's the name of it and how do I do the test? Like, okay, what is that purely infraspinatus, or are there other things that could help it? And also be aware that like that's not nothing's in isolation. It's just it's your best guess. Okay. So for the patients, takeaways, how do you know you might need surgery? You literally can't do something, like an inability to, whether that's due to extreme pain that changes quality of life, or inability to do it, or in particular, if you didn't have pain, like you're buckling. So if we have somebody's knee that's buckling out from underneath to them, you go to reach for something, oh, it's dropping. Now, is that in your shoulder? Is that in your neck? You know, that's maybe where you need a workup. And then the other thing, like Seth said, it's just like, are you over it? So we'll ask people sometimes like, hey, I know this can be rehabbed out. Maybe the timeline's much further out due to their just overall health status, their inability to stop doing something that's kind of picking the scab. And then you have to have a conversation of like, do you just want to have surgery and get this thing done and then do post-op PT? Because the dirty little secret, which I should have pulled up this research, if you look at a lot of the research on surgeries and then surgeries with the post-op rehab program, post-op rehab program standalone without the surgery kind of outperforms. So then we have to ask, well, is it just the post-op rehab, right? The 8 to 12 weeks of dedicated care. And then we see most surgical sides end up being better than the non-surgical side. So whether that's a knee, a shoulder, an elbow, hip, you're like, should we have just done prehab and seen what happened? Which I'll hit on that point real quick. So I looked up, I'm going to see if I can get this podcast sponsored by Consensus. So this is sponsored by Consensus. But I just typed in, so Consensus, if you're not aware, is an AI aggregate of, 200 plus million peer-reviewed articles. And it just basically says like, hey, this is what all these articles say about your yes or no question. So I said, does improving general fitness improve post-surgical outcomes? This has very quick, like 18-ish articles that it looked at. 56% yes. Most of us would say, oh yeah, that makes sense. Now, I think also this is just general exercise. If we did specific prehab of like a shoulder or something, you're going to have way better outcomes. Where I think I do a lot of this is like, I know somebody's going to go in for a joint replacement because that's just one of those scenarios where like, oh, I'm not really working on an injury. It's like you're in a bad spot, and like let's strengthen stuff up and do as much as we can before we go in there. So just like your recovery is better, but also like the things around that joint work better. And then one note on that is you don't always have to just work the bad side. So like generally working the opposite side and getting stronger overall has a neurologic effect, which is called the crossover effect. But there's studies too that if I'm going to have a right knee surgery or right knee replacement and I can't do a lot because there's so much pain or dysfunction, working just the opposite side gives me almost the same benefit. Like you lose about 10%, which is kind of crazy. All right. Yeah, there's still local stuff to do, but that's what you're going to do in post-op PTs, get that range of motion and strength back. So that's one thing we do like to be involved in is what could you do before you go into that surgery for maybe 4 or 6 weeks before to make it the best possible outcome? Because what we don't want is a failed surgery or just your overall fitness or health is the detriment to you. So then, yeah, so that both of these patients started with an at-home app. They were motivated. I don't think that's the best idea ever for a lot of reasons. These guys are the proof of why this is not a good idea. They did the entire 4 weeks at home. Guess what they're not going to be able to do? So like mobilize their shoulder like a physical therapist or whoever it is, chiropractor, physio, ATC, I don't care who you are. Soft tissue, some of the edema relief things. Yeah, you can put ice and heat on it. Both of these people came out of that 4-week window like so far behind where they should be. So neither one of them had external rotation, neither one of them had overhead flexion, neither one had an internal rotation, and both still had pain. So then we talked to the PT and she's like, what is going on? It's like, they did their work. I just don't think it's enough, right? Or it's not specific enough maybe. So then it's literally at 4 weeks out, like they're starting at week 0, which makes perfect sense with our guy that's like 18 weeks out. So if he was supposed to be released at 12, well, he's basically released now at 18, 19, like mild pain hanging from a bar and stuff like that. So if you're a patient out there or a PT or whoever, conservative MSK specialist, and we think that somebody is going to be as good as you are by themselves at home, that's just not the case. So whether these people are getting paid for what's called remote therapeutic monitoring, where you just check the exercise and get paid money, or they are just giving it to them because they think it's easier, or they think it's saving them money, right? Maybe they think they're doing something good for these patients. That's what I assume. I don't think it is. So if you've been given that as a patient, I would be like, no, I'm going to opt for just the post-op PT. And here's the kicker. We always tell our patients, hey, they're probably going to sign you up depending on what the surgery is. So let's say you have a slap tear repair and you're a 35-year-old guy and that's all they had to do. You should be released in about 8 to 10 weeks from post-op PT. So I always tell them, hey, about week 6, we want to see in our office, just take a look at like, how are things moving? But then how are the things around that area starting to function or not, dysfunction? So we can start helping this along, because that's kind of what gets lost on these cases is we get range of motion back locally, we get strength locally, and then maybe the thing that led us to that injury or things that happened since that injury are not great. And then we get right back into the same scenario when we get released to, baseball, CrossFit, whatever, running. So that would be a huge deal for me is if you have somebody that's, and no knock on like a traditional post-op PT or outpatient PT. That's not what I'm saying. Sometimes the things that got us there aren't worked on, and we just work on the pathology, which I think is pretty myopic. So always have somebody in your corner in a team approach. You need the post-op stuff. I don't want to do that. I don't think any of us want to do pendulums and soft tissue and put you in a game ready. I don't want to. But we're trying to make sure you don't get back there and you're actually better than you were. Any comments on that in terms of like, trying to think, there's no specific what we're doing. We're just coming in. If somebody had shoulder surgery, hey, what's PT saying you're at, like progression wise? Are you on track? Are you behind? Are you ahead? When are you supposed to be released? Check in with me maybe every 2 weeks until you're released. And then I'm going to see you 3 or 4 times and hopefully we're good. Right. So we always say we're just kind of cleaning up the ends there. And on that same vein, one thing that tends to happen in post-op PT is sometimes it's not challenging enough. So we call it kind of like you're undercapacitized, you're in like rehab purgatory, is you got out, you were cleared, and maybe it's not movement dysfunction or something that was leading to it. You're just not ready. And you get thrown back into the gauntlet thinking, oh, I was cleared, right? My return to play criteria was maybe not as hard as it should have been, or there was no RTP because I'm an adult that doesn't play a sport. And they're like, you're good. And you go back out and start running or gardening and you're like, God, some kicks. Yeah. doing something and they're like, ooh, we didn't test him hard enough to say, oh, you were good to go for that. Hence, again, it could be a strength conditioning coach, somebody like us, like somebody that can test you hopefully test you above the capacity at which you're going to operate all the time so you don't run back into an issue. I think that's a huge deal because we see people just get back out and they couldn't even do what they did before. Outside of that, if you do have a surgery or you're looking at a surgery, I would say one of the most important things we talked about prehab would just be like take a honest assessment of like how healthy are you. So if you've got like 20 plus lbs and you're crushing alcohol a few nights a week and your diet's not awesome, it would probably behoove you to just like clean that up rather than do prehab with somebody or any of that stuff we just talked about, of just like be an organism that can adapt to something like another trauma, like a scalpel through your labrum, better than somebody that's going to be inflamed and not have all those healing pathways kind of as optimized as they could be. But also that's going to benefit you anyways. So, and that's when we come in or patients come in here, we're always trying to address the biggest thing. So if you came into us for prehab, I think if we saw somebody like, you move pretty good, but like the Twinkies and the, Captain Crunch and the sweet teas, like that's probably like chill for a while, if not forever, especially right now, because that's not going to be the best thing for you. But that's what we're trying to do. Even if you don't want to hear it, like what is the biggest thing you should work on, regardless of what you came to us for. And if we're not the person that should be giving that advice, we'll try to refer you to that person. Any input on that? It's like you have a case right now where you're like, I think this is primarily functional medicine, and I don't think that patient thinks that, which can always be a tough combo,
Which one is that one? I got a lot. I feel like that. I like that.
We're in Alabama, so yeah, and that's probably everybody's practice nowadays. You were telling me about somebody the other day. I think it was shoulder.
The frozen shoulder.
Yeah.
He's on like some cholesterol stuff. It's had it on both sides before.
Yeah,
like, there's some pieces there for sure, especially in a guy. Frozen shoulder just for men are typically not like not common at all, especially not bilateral. One he had like just after like 4 weeks after having a labral surgery. That was like 10 years ago. This one just popped up. He has a labral tear in his shoulder. He knows that. And then it was just like 2 months ago, woke up and couldn't move his shoulder.
Mm-hmm.
But he's been on a cholesterol medication for the past like 10 years as well. He doesn't really know what his like A1C, glucose and all that is for like diabetic reasons, but he says he's not diabetic. Yeah,
we all are probably almost.
Says, but he hasn't checked.
Yeah.
Like doesn't know.
Yeah,
but also a lot of times they can be like, yeah, you're fine, and they're like riding that fine line of
yeah. My mom,
like vitamin D is like, yeah, you're good if you're like 5, and you're like they're at 7, and you're like, I'd like to get like 60.
I've seen numerous people, the cutoff's like 30 and they'll be at 29. Somebody's like, oh, you're pretty close to the normal levels. It's like, you're on the lower end of the normal level and you're actually in the pathologic range of that. Like, cool. You don't need that stuff.
That fluctuates daily.
Hormone receptor sensitivity doesn't matter, especially if you're a middle-aged female. So let's go back to these two specific cases. So like I said, both of them come in to post-op PT 4 weeks after not in great shape, where the PT is like, dude, I'm starting over. And that means they're going to probably have to be more aggressive, which is more uncomfortable for the patient. The patients are both active and wanting to get back to it. So now they're frustrated and starting to ask questions. And it just takes a longer amount of time. So by the time, and then this is just, you hate to say this is the way the medical system works. If you're in an insurance model, those PTs run out of visits.
Right.
Or at least paid visits via insurance, right? So if you get, 25 visits with the PT and you needed more because your shoulder sucks, you're either paying out of pocket, which can be a hefty amount for some people, or they're just like, hey, this is all we can do for you, which we hear all the time. Like you get released. So in that scenario, what do you do if you know something's not right or you're not able to do the sport or activity you want to do? Again, that's where it could be the same person. You just got to fork out money, or it's like, hey, I'm going to go to somebody that's like looking at all things instead of just the area that was injured, because sometimes it's not, you need to work on the tissue or we need to do more, ice or heat. It's like how you're using those things and how you're protecting those things is actually what's limiting range of motion, creating pain. Welcome to both these guys. So they both were getting a lot of like myofascial work and mobilizations, and it improved stuff. Like they got better, but then both of them are at these ranges. They're like, I can't get any further. I don't know why. So let's take the Highlands game guy. So severe limitation. So if you're watching the video, you kind of see what I'm looking at or doing here. when he goes in external rotation, he's like, all right, and this is a guy with like, cannonballs for shoulders. But here's the kicker. He's already out there throwing. He is going to compete here in a couple weeks, and he's set a PR like 2 weeks after I started seeing him. So like he's able to do stuff, but he has 0 internal rotation actively. Maybe 40 degrees external, inflection is like here. So I think, and I've told him, you doing that stuff is creating the problem. Your shoulder's having to put a parking brake on every time you just, have this like high velocity, fast activity. He's not going to stop. So then I have to kind of be okay with that because it's his shoulder. Say, okay, that's just more treatment, right? It takes more time. But what I said earlier was part of that like gigantic muscular overlay of his like deltoid and tricep is the thing that's also like hindering him, because we have to deal with like all these giant muscles that can just lock down. And like I've went in and needles hit his infraspinatus, and all of a sudden he's like, wow. But then like he comes back in the next time, it's the exact same. So we know that it's like this neurologic holding pattern. Well, if that persists for too long, you will get into legitimate like frozen shoulder, right? The capsule needs to move. Otherwise that capsule will have trophic change, and that's not going to be fun. And I've told him that. He's aware, and then he leaves, smiling and smirking, and I'm going to go do my thing, which is fine. Like we've addressed it. But, what do you do in those scenarios? I mean, that's a surgery, sometimes manipulation under anesthesia or heavy-handed, internal soft tissue stuff. But that's what he's doing. Now, the other guy, same thing. Like his lat was locking him down. He was having pain in the front of his shoulder. We started working around that. And I'd say, I think you saw him with me last time, maybe 99% they're on range of motion, just has a little bit of pain at end ranges and like doesn't feel completely comfortable hanging. So where he was at 6 weeks ago, right? Barely any external rotation, no, or not full range of flexion. It's like when it's not tissue, it's a different approach. So if you went through PT and you're still locked down, the chance of it being like, oh, they didn't stretch my capsule enough is probably rare. So just realize like if you go back to somebody like, we need to do more like mobilization and stretches. I'm not saying that's the case, but the likelihood is probably a little bit low if you just did 12 weeks of that and you're still stuck. Okay. So on a patient base, I hope that you take something away from that. Now, one thing that gets used a lot in post-op PT and even in here is like passive modalities, which we've mentioned a couple of times. Ice, heat, game readies, ultrasound, depending on what, decade you're stuck in. I don't know. What's your guys' take on passive stuff for like post-op? Like all that stuff that we mentioned, E-stem, any of that. When you see game readies, I'm not opposed to like icing something. I know icing's got this like, bad rap or whatever. If you're 4 weeks into like PT and your shoulder hurts after a PT session, like I don't care what you do to make it feel better.
Yeah.
To say that's going to blunt the healing process, like, okay, whatever. Because what are they going to do? Move more? Like you just work me for an hour and now you want me to move more because it's movement's medicine and I can't like lay here with like a passive modality. Like I think that's kind of crappy. Now 12 weeks out, if you're still using that stuff for your main pain relieving, I think that's where the problem lies. Of thinking you need those things at that point.
Yeah, if you count dry needling as a passive modality, that's probably our most.
Yeah, I mean that's a
one, but
I would say that's a big neurologic input too, though.
Yeah.
If I'm doing that on our Highlands game guy, I don't think I'm making a huge dent in like the muscle from a trophic tissue change. I'm like, let's break that holding pattern, use that temporary blip, and then like rehab around it or work with it.
I was going to ask you about him after you needle his shoulder and he has a lot more shoulder internal rotation.
And the time we did that, I just steccoed it, which was like killing him.
Yeah. So then in addition to that, were you able to find anything that he did at home after? Because I'm sure you sent him something home as far as soft tissue to do, but then like an actual exercise that he was able to do that.
Yeah. So we, and I kind of stole this from Austin Einhorn, so shout out to him. But he's big on, especially like when he's working with like his high level collegiate MLB pitchers, of this idea. If you're not familiar with Austin, go look up his Instagram. He's a great guy, Evolve Coaching, but talking about how, the great apes of evolution were like the only basically mammal that had a rotator cuff. So what that rotator cuff does for us, we all kind of know that, like helps depress your humeral head and the glenoid fossa. But to like make that work, you kind of have to be able to hang off stuff. Like that's the biggest component to that. And he goes, a lot of people just in general can't do that anymore, right? Just strength, whatever it is. So he goes like, if I'm a baseball player or a thrower, so we got this Highlands game guy, they should not be able to hang. They should be able to hang off one arm, maybe create like, independent rotation. So we got this thrower doing like 90 degrees, not completely off weighted. So he's on a box, heavy isometrics, then working in different angles, working towards a hang. That would, I mean, he got off the bar the first day in here and literally went like full external rotation. Now, that doesn't last very long, but that shows you right there. That's another diagnostic thing. What? That can't be tissue change. I mean, you literally just blew through it. But then he came back and he's like, dude, that is still really hard. My shoulder feels sore like internally. It can mean two things. Maybe he did have some like stiffening with the whole, how long PT took, or how he's using his shoulder when he does the hanging is probably not awesome. It's like, hey, let's just go down on the floor and like get a ring or a strap at 90 and start working that without that heavy load. And that's better for him right now. Just because he's not, I mean, he's huge. He's also weighs 250. Yeah. So it's a lot of weight. Same thing with the Taekwondo guy. He had much better range of motion. So I was like, you just need to start hanging, general hanging, right? Inside of his shoulder, doesn't like it. He is stiff. He's in this anterior shoulder position, stiff T-spine. I was like, let's take you down on the floor. And he's like, oh my God, that feels so much better after doing that. And like went beyond, perpendicular 90 degrees. He'll have to get to, he was doing the offloaded weight pull-up machine, right? Where you can like put 80 pounds on or whatever. It's like, just do some isometric stuff for the next week or two. And then like use hanging as a litmus test after you do that. Like try to hang double hand just for 20 seconds, see if your shoulder still aches like that. Because I think he can do it. I don't think he's getting hurt, but it goes back into the function thing of he sucked at that before. Like he had shoulder pain, bilateral flexion was limited due to his T-spine. It's like, okay, maybe his shoulder's post-op and it's not perfect. And he's like running right back into a dysfunction or a compensation thing. Yeah. So I just don't want to push him back into that too much. No.
What kind of work or rest are you having them deal with those ISOs?
Just the kind of Keith Barr stuff, not from, obviously it's not tendon, but just, I think there's a lot of neurologic stuff to that. So I don't go 40 seconds rest. So I was doing 10 seconds on because we're doing 100% isometrics. I mean, if I do any more, our throwers literally like purple and shaking, like, who's that? The Ultimate Warrior on the ropes before you're going for WWF, but 10 seconds on, 20 seconds off because like neurologic recovery is fast. Now, the further we get out and they get into hanging, I mean, I want to go into actual like duration thing. So it's like if we're doing an eccentric, we might be like, dude, can you do that for 5 to 7 seconds and you get a 20-second break? And then if you're going to hang, can you hang for 30, 40 seconds? All right. Or can you switch from left hand to right hand, single arm for 6 reps?
Yeah. I think about that 90 degree. I mean, that's a lock off. Like when we were climbing a lot, that was still really hard to do.
Yeah.
And we're not big people.
Yeah.
So which having the alternative of being able to pull.
And we'll do alternating grip on the pull-up bar. So they're like doing pull-ups or holds with the other hand. Yeah. And that's what I had both of them doing slightly offloaded. And they can both do it, but they're both like, yeah, it's kind of tough. And then we'll have them do like rotational pull-ups through there and just working their shoulders differently than they did because we don't want to just get them back to where they were. Like, especially the Taekwondo guy. He never had an injury and he's not throwing rocks around. Yeah. And it's his non-dominant hand. It's how he throws punches, how he blocks, how he does lateral flies, how he does a red press. That's what slowly created a slap tear and a non-throwing arm. So in that scenario, I'm like, oh, this isn't good. Like, let's work. And both shoulders have been painful in the past. So the likelihood of the same thing on the right's probably higher than the left. You just didn't have surgery on that one. So that's why I didn't think he needed surgery. Both have been a problem.
Yeah. Yeah. Whereas the other guy had the SC joint. Yeah.
But I think the key, like, again, talking about Austin Einhorn and kind of some of the stuff he does, like, he's just saying if you're going to throw, I don't know what the velocity of your arm is. We know what the velocity of a baseball is from this like false external rotation position, right? Because as you lead your body forward, you get further than you can actively. There's just a ton of force going through the glenohumeral joint. And then to think like, oh, we're going to do crossover symmetry and some stuff, and that's going to be like arm care. He's like, no, like go way above the capacity. And not only does that protect the shoulder, but it also like improve your performance. And that gets back into that rehab purgatory. Like, where did you get left in your post-op PT or rehab? We could go all the way, running, and somebody had an Achilles repair and you're like, oh, you got to release. It's like, can you do stuff that's harder than you were doing before? So we don't run back into an issue, whether that's just pain or a rupture or something like that. Because I think of local guy we all know around here that's a stud runner and cyclist that had Haglund's deformity surgery, and then a year later is on a mountain bike and almost goes ass over tea kettle and sets the bike back down and feels a big snap and thinks he broke the crank on his bike, and it wasn't his crank, it was his Achilles. It's like, should your Achilles snap in that scenario? Probably not. But like, was there some stuff that could have been done to prevent that? I think so. And that sucks, but yeah.
The thought of that happening to my Achilles.
That makes me want to lose my lunch.
I saw a guy go up.
Achilles rolling up.
I saw like a 65-year-old guy. We've been watching a lot of American Ninja Warrior because Maddox is into it, and he was going up the warp wall. You just see his foot stay flat, and his like leg goes out, like, and he just goes, "Ooh!" And he looks at it, I don't know, his daughter or whatever, and he's like, "Ugh." And he's like, you can tell he's freaking out, but like the action of his, like, it looked like his toes touched the front of his shin. Yeah, that's gross. Yeah, I worry about that, but that's why a lot of our people were like, you can't stop jumping. Like, that's that old Russian saying, when you stop jumping, you start dying. Like, you stop losing those springs, then you want to go sprint with your kid at soccer. I don't know. That's I mean, most common injury or acute injury in men over 40 is like pick up basketball, Achilles ruptures. Yeah, I can do that. Just get going. And, yeah, I don't know what's that. To keep sprinting, keep jumping, all that stuff. Trying to think of anything else specifically on these guys. So both are back at doing everything that they were prior, just not perfectly. And again, should our Highlands game guy be doing what he's doing right now? In my opinion, no. But he's doing it anyways. So just makes it tougher for me, to be honest with you.
Is he still working out, or is he just doing implement stuff?
Oh yeah. And again, he's overhead stuff. Like, he can, so here's another key with him that, yeah, it's a good point. Probably a week after I saw him, which would have been about 5 weeks ago, if he was loaded, he would have full range of motion. So this is a guy, like, if you're watching me, like, he goes to lift his arm, you get him a kettlebell. So why? Because his rotator cuff has to depress his humerus. When he's not loaded, it kind of takes over. It's like, dude, I'm just going to lock your shoulder down. Welcome to the party with most of these like post-op shoulders that look like a frozen shoulder. It's like, no, you're reversing the function of your rotator cuff. Instead of it literally allowing you on a flexion, it's just going to lock you in a position that limits flexion. So like we couldn't, so then he gets a false flag because what? He can still throw, he can still lift. And they're like, well, I can't do this. Or if I sleep in this position, like coming out of it in the middle of the night is torture. Yeah, so he's working out, and then he's like he can't get into front rack, but I saw him front squatting on social media, like 400 pounds or something. And the guy's a behemoth. So yeah, that's fun. But you see those things and you're like, hey man, but that's where you got to be honest with people. Like, what's the risk of doing that? Tell them. If you told them and they're okay with it, it's not your body. But on that note, still talking about surgery, which I'll see this guy for follow-up today. I just saw him 2 days ago. It's a patient that I've seen for a long time. He came into me on his first visit years ago. This would have been 3 years ago. I told him, you need a hip replacement. He was like, I am not getting a hip replacement. I was like, okay, I will work with you. But like, we're talking zero range of motion on the hip, pain with everything. It's starting to mess his knee up. He had a prior Achilles surgery. He didn't have extension of his knee. So I just start chipping away at stuff. Let's get your knee moving. Let's get your hip moving. He did pretty good, being honest, like better than I thought he would do. We had him doing split squats and all sorts of stuff. That I was like, and on his last visit, which would have been about 2 years ago, I said, if you feel like you are good, again, get back into that. Do you want to have the surgery? What's your quality of life? You make the call. If you feel like you're doing okay and you get 6 months out, I'll consider that good. So I didn't realize this until he came in the other day. He had called in about 6 months ago or 7 months ago, called in and said he was having a really bad flare up of his hip for the past 2 weeks. And I just told our front office, I say, hey, can you just tell him to get an ortho consult? Because I told him if I ever had to see him again, like, it was surgery time. So they sent the referral in. He never went, which is kind of funny because his significant other was with him and she didn't know that. And I didn't know. And I look and go, oh, hey, I put a referral in for you to a local hospital here. He goes, you did? I go, yeah, you're supposed to have surgery next time you saw me if something flared up. And she goes, oh, and it was like, he was in trouble and he's just sitting there like giggling. So I looked at his hip this time. It's worse. And now he's having back stuff and radiating pain. And I basically was just as truthful as I could be. I go, I can treat your back, but it's going to lead right back to your hip. And then that leads right back to surgery. So like my strong opinion is you need surgery. And he's still like, I don't want to do it. I go, then you got to get an image. And we got an image of both hips. And that hip is no bueno. Just we knew it wasn't. He had a little styrofoam squeaky when I said, hey, you hear that squeaking in your hip? He goes, yeah, it sounds like a chicken bone rubbing against. I go, yeah, that's basically what it is. So that's one of those scenarios. He's at the point, I won't work with him anymore. That makes sense. Like it is a disservice to that guy to keep working on his low back and not say, if you don't get this hip surgery, like you're going to wreck other stuff. And he knows that, but it's not me being nice, being like, yeah, I'll treat your back. Now it's like, that's malpractice in my opinion. Like, hey, yeah, I'll keep treating your back when his hip is the driver. Now, if he don't have surgery and he wants to go someplace else, that's up to him at this point. But when he comes in today, I'm gonna have that little bit of tough conversation, but the writing's on the wall now. I mean, I can show him his hip looks like it's made out of Play-Doh. Just be like, hey man, like that's what we thought. Like your back's gonna be tough to treat, and yeah, I'm not gonna make your life easier. So hopefully he does it. He's just scared. And then the little bit of me, and this is for patients out there listening, it's like, oh man, you're gonna push somebody to surgery. My worst fear is that he does have a complication. Then I'm the person that pushed him into surgery. So yeah, I'm worried about that too. But like that is the best choice for him. There's always a complication. You could have a lipoma removed and have a terrible infection or something with some of the minor, most minor surgeries out there. So it's always a risk. Anything else on, because I had in here like surgery prep, the rehab of it, beyond surgery. I think we've kind of hit the clinical ends, the patient ends, everything in between. Yeah, I don't know. Anything else? Yeah. So if you get told you need surgery, we always say get a second opinion. I also wouldn't get a second opinion from the same type of physician.
Yeah.
So if you get an ortho that says need surgery, because we've had orthos that'll literally one will say no, one will say yes, one will say no, and not only no, but you don't have the thing that I think they're operating on, which is kind of odd. So I would just say, well, go. And we'd always say start conservative first anyways. So you should do some prehab. You should do some conservative care to rule it out, because that's something you can go backwards from. You can't go backwards from surgery. But if let's say you do see a chiro or PT or an ATC and they're like, you don't need surgery and your quality of life sucks, and they don't want you to get consult for somebody, like go get the consult. It's your body. And then vice versa. If an ortho tells you need it, go see somebody conservatively. If a conservative person agrees with them, do it. You better believe, unless they're not competent, they're like, ooh, I got two different people in two different professions tell me to go do the same thing. So it's probably time to make that move. So if you're a patient or you doc and you got questions about something about surgery, please don't ask us questions about your surgery. Like we're going to refer you right back to somebody locally that can actually like see you as a patient, both legally and just ethically. But if you have questions, comments, let us know. And also let us know what you want to see for the next 9 episodes of the Week in Review. Anything before we jump off here?
I'm good.
We'll be taking bets on what kind of facial hair Alex has on the next episode.
Running out of options.
You
Good.
grow a Fu Manchu? Can you get it down the sides? Or you got a gap?
Very minimally doesn't connect.
Fu Man gap?
It's a man gap.
No.
Yes.
Yeah. Take bets. Put it in the comments. See. Thank you for tuning in. Please subscribe via YouTube, Apple Podcasts, or Spotify. If you like the message, please share it. We appreciate it. Thank you.